Good evening, everyone. Let's start. So, welcome to the 16th edition of the Masterclasses, which are conducted by the Jaipur Surgical Tutorial. The theme today and tomorrow is Carcinoma of the stomach. For those of you who are joining the Masterclass for the first time, just a brief introduction about Jaipur Surgical Tutorial. This is a free, no registration fee, online education portal for surgical students, mainly MCH students in GI and HPV surgery. But I see that a lot of general surgery students have also joined us, which we have been running for last more than 3 years. This is being moderated and controlled the activities by my colleague, Dr. Anand Nagar, who is a professor of HPV surgery and liver transplant with me at the Mahatma Gandhi Medical College and Hospital in Jaipur. In the Jaipur Surgical Tutorial, every Saturday morning, 9 to 10 India time, we conduct an online session where students by rotation, they present cases or operative procedures which are discussed by the faculty. And all these classes are recorded by a team from Dr. Avinash Tak, who is my former fellow from SGPGI and now a consultant GI surgeon at Dwarika Hospital in Ahmedabad. About 1 year ago, we started these masterclasses, which are done on the last Wednesday and Thursday of the month, 7 to 9 p.m. India time, where we select a theme and we have 2 sessions of 2 hours each. In each session, we have 1 or 2 moderators and 3 or 4 panelists to discuss aspects related to the theme, and then there is an open house session. Also, under the auspices of my current institution, the Mahatma Gandhi University of Medical Sciences and Technology, we have been conducting an annual continuing medical education activity called Jaipur Surgical Festival. We've already done 3 festivals in last 3 years, and the 4th festival this year is 6 to 8 December. The theme is complications in surgery. So all those who are interested to attend in person can visit the website. If you put Jaipur Surgical Festival in the search, it will take you to the website. And in any case, we will be also streaming the entire proceedings live on various platforms with the help of the team from Dwarika Clinic. So all the students are welcome to attend live. And all these activities of Jaipur Surgical Tutorial, the masterclasses and the previous 3 Jaipur Surgical Festival, all the videos have been uploaded on the YouTube channel of Gastro University, which are free for students to watch. So with that brief introduction of the JST, JSF and masterclasses, I come to today's first part of the 16th masterclass of Jaipur Surgical Tutorial. And today, I have specifically requested my former colleague from SGPGI and currently a professor of surgical gastroenterology and liver transplant at the prestigious All India Institute of Medical Sciences in New Delhi to moderate this session. Dr. Das has had, like me, the fortune to work with one of the leading esophageal surgeons of the country, Dr. T.K. Chattopadhyay, and I think a large number of those of us who do esophageal surgery have learned the tips and tricks from him and are trying to take it further. So with that background, I would hand over the session to Dr. Das to moderate. Also joined is my colleague from radiotherapy, Dr. Anushri Loyal. She will be participating actively tomorrow, where she would be giving us a brief overview of the role of radiotherapy in the control of bleeding and especially unresectable carcinoma of the stomach. Continue to moderate, and wherever required, I will chip in. In between the sessions, for the sake of students who are joining for the first time, I will project information about as to how you can join various activities of Jaipur Surgical Tutorial by contacting my colleague, Dr. Anand Nagar. So with that, over to you. And I also specially welcome Dr. AIIMS, who is a very senior surgeon from the neighboring country of Myanmar. We have never met, but we have been corresponding on email and WhatsApp for a long time. And I hope that we will see Dr. AIIMS in India sometime. And I hope that I will be able to carry a a group of Indian faculty to Myanmar to conduct a CME program in your country. So welcome, Dr. Aimon, to the.
Thank you very much. Yeah.
Das, please carry on.
Thank you, sir. Thank you very much. With your due permission, I want to correct a little bit. I was never your colleague in SCPJ. I was your student. Now I have become a colleague in the Gastro University, of which you are the vice chancellor.
No, all of you are my very eminent, very prominent colleagues. I'm very happy that all of you have done so well that you can take over all these activities from me gradually. Please,
Yes,
please.
sir. Yeah, you are absolutely correct in saying that I have learned a lot of this gastric. I was into this gastroesophageal surgery because of the influence of Professor T.K. Chatterjee in AIIMS. And I am into active research in gastric cancer since 2007. So we have been conducting surveys in North India and all those areas where it is very, very rampant, you can say. Now, this cancer itself has been a headache to the human being since long time. Now, as we are sitting here, about I can see 10 people. One of us is likely to develop cancer in a lifetime. It's 10 out of 1 out of 10 in India. That's the Indian statistics. That's what the ICMR 22 study says. And there are about 100 per 1 lakh population cancer suffering from new cases of cancer. Stomach cancer, once when we were studying, it was called the cancer of death, the captain of death. But I think due to the rapid development in early diagnosis, particularly the molecular ones, the immunology part of it, the early diagnosis, early treatment, uh, it is possibly no more occupying that dangerous position which it was having, and we are now being able to satisfactorily treat and get a acceptable longevity of survival, complication free survival, recurrence free survival, according to the standard of malignancy that is prevailing all over the world. The two important parameters that determine the survival or recurrence rate for most of the type of cancer, particularly the GI cancers, one is the margin, one is the lymph nodal status. So there is no question about these two. Others may vary. The margin part is a debate, and I think we will discuss this one in the next session tomorrow when we discuss about the surgery. And the lymph nodal status is very important for gastric cancer management. And though we have a difference of opinion in the Western versus the Asian data or Asian practice, I have seen some of my teachers or seniors practicing according to their own, you can say, guideline. Their guideline is to follow whichever guideline comes in their way. In the sense, if they like this particular surgery to be done or this particular method to be adopted for management of the gastric cancer, they will apply the particular guideline which is suitable to them. So thereby I mean that still the guidelines varies. Still the Japanese people are conducting trials to establish what is there in the European literature before actually accepting them. So to know the management of the cancer, successful management of the gastric cancer, we need to know the incidences, the etiology, the molecular biology, the genetics, early diagnosis, management, recent developments in the investigation aspects, particularly the imaging, the PET scans, the endoscopies. There are lots of development in that. So to know the management, we need to know what is the etiology, and to know the etiology, what we need to know what is the surgical anatomy of the stomach here. The more or less, there is no confusion regarding the vascular supply of the stomach, the layers of the stomach, the parts of the stomach. All these are more or less standardized, not much of a variation. Where there is actually the variation and things are changing with time and the differences between Asian and European communities and other areas also. So that is the lymph nodal anatomy of the stomach and lymph nodal retrieval, the status, the importance of lymph nodal dissections. So to know this, let's start with the discussion of the lymph nodal anatomy of the stomach. And for that, I will be, with the permission of Professor Kapoor, invite again Dr. Aimon from Myanmar to give his talk on this particular topic, which is important for us, and I think it's a very important for students' point of view.
Thank you.
Dr. Ayman, please.
Yeah. Okay. So good evening, everyone. This is my very first talk to the GST Masterclass. Really thanks to Mr. Professor Vicky Kapoor inviting me to such a very honorable class. So today my topic is lymph node anatomy of the stomach, especially in relation to the gastric cancer. This is the basis anatomy topic. As Dr. Dash talked previously, it's very important to know these lymph node anatomy for the diagnosis and later surgery. So carcinoma is one of the very common cancer worldwide. The lymph node spread is a very most common mode of spread. So lymph anatomy is essential for the acute staging and R0 resection. The stomach has a very rich network of the lymphatic drainage in the submucosal layer and very dense lymphatic network in the multidirectional omentum and mesentery. So in the textbook, they describe the stomach has the largest number of regional lymph nodes of any organ in the body. Largest number of the lymph node in the stomach. And the lymph nodes are designated to the organ, the attach or the by the nasal artery. It follows. For example, here is the cardia stomach. We got here lymph nodes, the right paracardia, left paracardia. In the pylorus, suprapyloric lymph nodes, infrapyloric lymph nodes, and spleen-hilar lymph nodes. And then sometimes they tell according to the artery, leg gastric lymph nodes, ciliary lymph nodes, etc. So the basically we all know in stomach here's the lesser curvature, greater curvature, and the cardia here is a pyloric entrance and pyloric canal and anterior and posterior surface. So the importance of the lymph node spread, first we must know detail about the arterial supply, as Dr. Dash described previously. And the stomach mainly supplied by we all know this is the ciliary tract. From ciliary tract, this is the leg gastric, which mainly supplying the cardia and the upper part of the lesser curvature. And then spleen artery, which go behind the stomach and to the spleen, and that spleen artery give the multiple short gastric artery to the greater curvature and leg gastric epiploidy artery. And then another artery is a right gastric artery, which comes up from the common hepatic, which is one of the main branch of the ciliary tract. Right gastric artery is supplying the lower part of the lesser curvature region, and the another artery is a right gastric epiploid, which comes up from the gastrointestinal artery. These arteries supplying also very important to study the lymph node groups. But in general, we have the stomach lymphatic drainage in 4 zones described in the undergraduate students. And then arbitrarily, we divide stomach the right half and the left half. The upper two of the right half, mainly the Lasaka region, including the cardia, they usually go to the superior gastric groups or lymph nodes. Basically, then lower third of the right half go to the suprapyloric group lymph nodes. And another half near the along the greater curvature, above that go to the pancreatic or spleen lymph nodes. And the distal two of this left side mainly go to the inferior gastric subpyloric group. These all lymph nodes finally go to along to the vessel, they reach to the celiac group, then to the para-aortic and systemic. So here the full lymphatic channels are zone 1, 2, 3, and 4. Previous I mentioned, finally they go to the leg gastric, splanate, and common hepatic and ciliary lymph nodes, then to the para-aortic and systemic spreads. Then again, we can describe the lymph node anatomy of the stomach at a 3 group. Here, the right paracardia, left paracardia, and the lesser curvature lymph node, greater curvature, suprapyloric, infrapyloric. These groups are known as the perigastric group. In other words, they call the tier 1 group, or there's a compartment 1 lymph nodes. Then here the 7, here is a leg gastric, 8 common hepatic, and 9 celiac. The 10 splenic hyaline and 11 splenic artery, they are the second tier group. They are not extragastric, but very near extragastric group. From them, they reach to the hepatic hyaline 12 and 13, 14, up to 16. They are the far extragastric group. That means that we have the 3 division of the lymph node very basically. I will mention detail about the lymph node into the station. First, the perigastric lymph nodes, tier 1 lymph nodes include lymph node station 1 to 6. We also know at the compartment 1 in staging, there is the N1 lymph nodes. Station 1, previously known as the right paracardial lymph nodes, is along the, there is a ascending branch of the, first branch of the ascending limb of the left gastric artery. This is the station 1 of right paracardial lymph node. Station 2 is known as the left paracardial lymph nodes. It is related to the isobucocardial branch of the left saphenous artery. This is station 2. Station 3 denotes along the lesser curvature. It is here 3A and 3B. 3A is along the distal branches of the left gastric artery, 3A. And the 3B is the distal branch along the distal branches of the right gastric artery. So in the lesser curve, there are 3A and B. And the greater curvature, they are the station 4, 4SA at above of the greater curvature along the short gastric artery. Then 4SB along the left gastroepiploral artery. But the 4D at the distal portion of the greater curvature, this is branches of the distal part of the right gastroepiploral artery. So generally, there's station 4s are along the greater curvature. Stage 5, previously we know the suprapyloric group. This is the proximal part of the right gastric artery. This is the suprapyloric or stage 5. Then stage 6 is the infrapyloric lymph nodes. This is the usually we divide into detail 6A, I, and V. 6A related to the right gastroepiploral artery. 6I along the infrapyloric artery. 6V is the lymph nodes along the confluence of the right gastroepiploral vein. This is stage 6, generally we know as the infrapyloric lymph nodes. So stage 1 to 6, we got the tier 1 or compartment 1. This is the perigastric lymph nodes. Then the another stage 7 to 11 are known as the near extragastric lymph node or tier 2 lymph nodes or compartment 2 lymph node. These stage 7 is related to the left gastric artery at the main trunk of the left gastric artery, stage 7. Stage 8 is related to the common artery. 8A is anterior to the common artery. 8P is posterior to the common hepatic artery. Stage 9 is celiac artery lymph nodes. So 7, 8, and 9 around the celiac trunk. Here's the tier 2 main tier 2 group. Usually most of the perigastric lymph node finally reach to that tier 2 7, 8, and 9. And stage 10 is the splenic hyaline lymph nodes. It's along the splenic artery, splenic hyaline, distal quite close to the pancreatic duct, stage 10. Stage 11 is splenic artery lymph nodes. So along the splenic artery, they are the stage 11. And 11P is a proximal portion of the splenic artery. 11D is the distal portion of the splenic artery. The demarcation line is the posterior gastric artery. So with stage 7 to 11, we are known as the tier 2 or compartment 2. Then the very distant extragastric lymph nodes, tier 3 lymph nodes are station 12 to 16. Compartment 3. Here the station 12 is generally known as the hepatic hyla, near the hepatic hyla. Is the 12A is along the proper hepatic artery, 12B along the portal vein, and 12B along the common hepatic binders. Generally, these 12 lymph nodes station 12 are around the hepatic hyla. And the 13, they are posterior surface of the pancreatic heads, sometimes known as the retroduodenal lymph nodes. And the 14V, along the supramuscular vein, they are very far distant lymph node. Then stage 15, along the metacollic vessels. Stage 16, the para-aortic lymph nodes. From the diaphragm hiatus to the bifurcation of the aorta, 60 A1, A2, B1, B2. So these, stage 12 to 16 are tier 3 or far or distant extragastric lymph node. So lymph node 1 to 6, compartment 1, 7 to 11, compartment 2, and 12 to 6, compartment 3. These are the deep picture also described here 1, 2, and 3, A and B, 4, SA, short gastric, SB, 4D, and 5 here, around the right gastric, the 6, this is the first tier. Now 7, leg gastric, 8, common hepatic, and 9, the celiac. Tier 2, then 10 is the splenic hyaline, 11P, proximal splenic, 11D, distal splenic, and 12 here is a hepatic hyaline, A artery, P a portal vein, B related to the behind that. 13 is a retro pancreas, 14 SMV, the 16 is para-aortic. So lymph node metastasis depend on depth of the submucosal invasion and the site and region of the tumor. But there are stems, the skid metastasis. Generally, the submucosal invasion up to 300 to 1000 micrometer. 1000 micrometer is 1 millimeter. At that invasion, there is about 20% of the lymph node involvement. But mainly to the perigastric lymph node, only 20% go to the extragastric lymph node. But if the invasion is more than 1 millimeter, that means 1000 micrometer. There is a perigastric and extragastric involvement is quite the same. That depending on the region and the above that tumor here, above that tumors, usually they have a node metastasis is 65 to 80% if the advanced gastric cancer, but maybe early gastric cancer, they be 2 to 50%. They involve station 1 here, station 2, station 3, and station 7, 9, and 10. 10 is very high, especially tumor located at the greater curvature of the posterior wall. And the metastatic tumor usually involve the station 1, station 3, station 4, and station 6, and 7. Sometimes the stages 10 and 16, they are less frequently involved. For the lower third tumor, they frequently involve the 3, 4, 6, then 7, 8, 9. Sometimes they involve in the stage 14 SMV. So this is a lymph node area depending on the tumor sites. They are very generally speaking. But they are skid metastasis. They can spread to distant lymphatic station. Frequently they involve the leg gastric, common hepatic, and celiac trend 7, 8, 9. So there's without involving the perigastric, they can reach to tier 2 or tier 3, about 5 to 40%. So I want to include my topic, lymph node anatomy, but I don't want to mention here because the next speaker will mention about the lymph nodes into the end station and some lymph node involvement in the nodal dissection and D1 or D2. So my topic is quite a basic anatomy topic. So lymph node metastasis is very important. So we must know about the thorough anatomy of the lymph node station sites and relation to the vascular supply. So we can do the correct lymph anatomy. Thank you very much. This is my reference.
Thank you very much, Dr. AIIMS. So that was actually a very exhaustive and elucidative description of the lymph nodal stations, the lymph nodes, the number of lymph nodes that can be really maximum we can see in the anatomy book around the stomach. And it's so important to select the proper group of lymph nodes and the number of lymph nodes depending on the situation of the tumor in the stomach. That's what you said. And now that we are, so it is also important if you could highlight a little bit it's not that the berry picking of the lymph nodes while doing cancer surgery is actually the lymph nodal removal. It has to be a little bit lymphovascular tissue, isn't it? And we should know the proper plane of removal of the lymph nodes, whether it should be very close to the capsule, whether a little bit away from the capsule, include the fascia of the lymph node. That's what has been also explained by the Japanese group very well. Now that we are, if you want, you can give us some idea about the technique of lymph node removal in these patients, depending on the guided by the anatomy of the surgical anatomy of the lymph nodes. One, Dr. AIIMS.
Yeah, I'm just basically and principally the lymph node removal. If it is depend on the D1 or D2, but I don't mention D2 here. But if the tumor involve the lymph node, that is perigastric tier 1, we should remove the tier 2 group basically. If it is tumor is separate to the tier 2 group. That is the celiac, so left gastric or comorbid. We need to remove beyond that level. That is a tier 3. But there is some study, they're not very sure about the benefit of the tier 3 removal. I'm not sure about the data. But general principle, we should remove. If it is an environment, lymph environment N1, we remove the N2. So this is a very, very basic principle, as I know.
Yeah, I basically wanted to ask you that we will discuss tomorrow. But what I wanted to know is it just berry picking of the lymph nodes, pick and pluck of the lymph nodes while you are doing the gastric surgery, or you should get some idea about the lymphovascular clearance, so the lymphatic, the fat, and the tissue clearance along with the lymph nodes that we say as N block during the surgery.
Sure.
Do you have any tip, trick of the trade? Any trick, anything we keep in mind while doing the removal of the lymph nodes?
No more trick. Yeah, just to remove as far as possible the M block. Yeah, that's a good idea, but not as if possible. Don't touch technique, especially because lymphatic spillage is very common. And if it's possible, we use clip-in. But generally, in our country, we are still using some tie, suture. But if it is, we can use some clip and some very good hemostatic is better because the lymphatic spillage is very, very common.
Anything to do, anything to prevent lymphoria in the post-operative period when we are doing so much extensive lymph node surgery?
Yeah, sure.
So which energy source you would like while removing the lymph nodes? What energy source you use? Some people they cut it and then do hemostasis. Some people go on cutting through by scissors. Some people prefer harmony scalpel. Some people prefer their diathermy energy.
Yeah. I think I prefer the harmonica based. I think prefer here. Yeah.
Maybe we will more of tomorrow's session. And I would also like to introduce two more panelists who have joined. Dr. Sadaf Ali. She is the chief of GI surgery at SKIMS in Srinagar. And in between, I saw Dr. Subramanian also joining, although they are panelists for tomorrow. But please welcome them. Yeah, that's please carry.
Experimented with the surgical anatomy, the lymph nodal part of the stomach, and we are more or less also we learned about the vascular supply, the parts of the stomach draining to a particular group of lymph nodes from Dr. Aimon. And the next thing we should know is about the etiology of this gastric cancer, which is, I think, is not a part of it. If anyone is covering in part, then it's fine. But the more or less the etiology of the stomach is no more debatable. And I would say that only one thing that more and more the H. pylori infection, the eradication of the H. pylori infection has definitely reduced the incidence of the cancer. And the other etiology are more or less standardized, and it's according to the incidence of the stomach, varies globally also. So with that, we would move to the diagnosis and investigations, diagnosis of gastric cancer.